So it's great to see everybody this morning. Enjoying that?
That's great.
Good. I thought I'd just sort of go over some general management strategies, and all of you have probably heard most of these things before, but just to have them all in one place and think about sort of general principles is what I thought would be useful. Feel free to stop me, ask questions. We're such a small group and informal, and happy to take questions as I'm going along. You know, I think Dr. Wu's statement about starting low and going slow is probably the major theory or tenet that we should apply for everything we do in treating EDS. You know, even with this device, started at a low setting and then slowly increased. So we'll come back to that many times as we're thinking about the different aspects of this condition, which as all of you know, is a complex and multidisciplinary disorder. Like pretty much every organ system you can think of is involved in one way or another. And Heidi Collins, who used to be the chair of the medical advisory board for the Ehlers-Danlos Society, said, if you can't connect the issues, think connective tissues. So that's what we're trying to teach professionals who are seeing patients and coming in with all these seemingly completely unrelated complaints, and EDS is the diagnosis that pulls it all together. So you're going to hear a lot more about the musculoskeletal involvement from our PT team in a little bit, so I'm not going to really go too much in detail about that. That's really where most people first get recognized, is with the joint laxity or instability in the joints, subluxations, dislocations. There is also a tendency for tears in the soft tissue, the tendons or the ligaments. Chronic musculoskeletal pain, as you all know, is really very, very common, and it's a result, I think, of the previous things, the joint laxity and the instability. And then many people have frequent sprains, particularly the ankles, which tend to roll. So just some sort of general musculoskeletal strategies. In general, what we're trying to do is a combination of muscle relaxation and then muscle toning and strengthening. You don't want to do one without the other. And equally, it's hard to do the muscle strengthening and toning if you don't get the muscles relaxed. And it's not a good idea to do the relaxation without the toning and strengthening, because then you kind of enhance the laxity and the instability. So we try to stabilize the joints only on an as-needed basis. Some people worry that if we use braces, we're going to weaken the muscles. But if you use the muscles on a continuous basis or consistently, you can brace when you need it. If you're in a situation like if you're in the car and your neck is unstable, you want to be using an Aspen Vista collar to help stabilize your neck. If you're doing a long walk and your ankles tend to roll, it's a good idea to put ankle stabilization braces on. But if you're not in those situations and you don't need the stabilization, then you don't use it, right? Physical therapy, you're going to hear all about that in a little bit, including the myofascial trigger points. And the electrical stimulation, many of you have had exposure to TENS machines or eStim in the PT office. And the TENS machines now, the sort of generic TENS, has gotten really quite inexpensive. There's a good device called the TENS 7000 now that's available for less than $30 online. So Epsom salts, we've spoken about Epsom salts, magnesium salts. Those are really, really good for muscle relaxation. The muscles, there's a molecular mechanism for tightening of the muscles and relaxation of the muscles. And when the muscles are in spasm, in order for them to release, you need a magnesium ion to go right. There's a spot that the magnesium ion has to go. And if there's no magnesium to slit into that position, then the muscle is not going to relax. And many of us now are magnesium depleted. The food supply has become magnesium depleted. Our soil is magnesium depleted because of the way farming is taking place these days. So farmers used to rotate their crops, and that would enable the soil to be repleted of the nutrients that were drained from it from the process of farming. What I understand is the only place on Earth where there's adequate magnesium magnesium in the soil is the Nile Valley now. So, so we all need magnesium. I think supplemental magnesium is a good idea for pretty much everybody. And yes?
Would it be prudent to like specifically take a magnesium supplement before a PT appointment, or like is there anything to support like strategizing the
I don't really think so. It's kind of a long-term game because we have most of our magnesium is intracellular in the body. But there is a requirement for a certain level of magnesium circulating in the blood in order to keep the heart rhythm normal. So that's a high priority for the body. So the body will take the magnesium out of the muscles and the bone in order to keep your circulating level at the level where you need it for your heart. And you have to be really, really, really severely depleted in order to have a low magnesium level in your blood.
So the blood is usually fine. The body takes it from the muscles and that.
Exactly. Yes. So there's magnesium, there are lots of different kinds of magnesium that you can buy online. So you can get magnesium glycinate, carbonate, citrate. I myself use magnesium carbonate. It's the product is called Natural Calm, and it's a powder that you just put 2 teaspoons in a cup with warm water and drink it like a tea. And Natural Calm, C-A-L-M. They make one kind that doesn't have any flavoring, and then they've got a couple different flavors. There's a raspberry lemon one that's like a raspberry lemonade, warm raspberry lemonade that's really good tasting. And I drink that at bedtime. It helps with sleep, and it helps with any kind of muscle cramps at night. And just 2 teaspoons provides your recommended daily allowance, which is 350 to 400 milligrams a day.
It's also really good for constipation.
Magnesium in general, like milk and magnesia, magnesium citrate is usually used for yeah. Okay.
Are there foods that are more magnesium rich? Others that you would recommend? It's not something I've ever
Magnesium, yeah, chocolate has a lot of magnesium in it. That's yeah, I don't know. That's not something I've thought about. Sorry. But the Epsom salts, I started talking about magnesium because of the Epsom salts, which are magnesium salts, and your skin absorbs them, and then that gets into your circulation through that mechanism. So you can either take a warm bath with Epsom salts or just a foot soak. If you're soaking your feet in Epsom salts, the skin of your feet will absorb that magnesium and it'll circulate throughout your whole body, and all the muscles will benefit even though you're only soaking your feet.
And they do have neck sprays as well. They're like on oil base.
Yes.
I like to put it on like my hand and then dab it like on my temple and my jaw, and that tends to help with like muscle tension.
Good idea. And back to the PT for toning and strengthening, you're going to hear more about that from our team. And I prescribe this compounded analgesic cream. I've probably given all of you prescriptions for that. We're having more and more difficulty these days with insurance covering any compounded product. So it's less of a utility for us now because it's hard to get it covered. But if your insurance will cover it, it's a really, I think it's a useful adjunct to have it around because it does have those 2 muscle relaxants in it and the local anesthesia, as well as the non-steroidal anti-inflammatory. So when we prescribe it now electronically, I can't include the gabapentin because gabapentin in Indiana is now rated as a controlled substance. So we're not allowed to prescribe those electronically anymore.
Yeah, I had to present my ID to pick up.
I was wondering when I picked mine up, it was like...
Yeah, that's why. Yeah. We use muscle relaxants if necessary, but just like we were saying about doing the muscle relaxation strategies for physical therapy, if you're using those muscle relaxants, you run the risk of increasing the joint instability because the muscles are doing a job. They're trying to hold things together with the muscle spasm. So you have to be careful about that. But if the muscle spasm is really creating a lot of discomfort and pain, sometimes we need to use them. And Botox can be very helpful. People are using Botox for migraines, for muscle spasm in the scalp, for muscle spasm due to temporomandibular joint dysfunction, and it can be really a useful tool for that. The one area I would really be careful about is any kind of Botox in the neck muscles, because once you lose control of those neck muscles, you can't hold your head up anymore. And you don't want to be in that situation for 6 months, six weeks, I guess is what it's going to be lasting. So just be careful about that. All right, then our cardiovascular manifestations, the orthostatic intolerance. So many of you are also living with this, where you go from lying down to sitting up or standing and the heart rate just starts racing. There are two different things that can happen with changes in posture. You can either increase your heart rate, or some people will drop their blood pressure. Some very lucky people do both. And that is really, a decrease in the blood flow to the head, and then you feel woozy, dizzy, in the extreme, maybe faint. So we'll talk a little bit about the strategies to mitigate that. Mitral valve prolapse is another thing that we see in a lot of people with Ehlers-Danlos syndrome, and then the aortic root dilatation is not that common in EDS, but we do have to look for it. If we find it, the aorta it's a little bit dilated, but it doesn't tend to grow as it does in some other hereditary connective tissue disorders. So we like to know if it's bigger than we expect it to be, but we generally, as long as we've excluded other hereditary disorders of connective tissue where it can be a dangerous situation, we don't worry about it in hypermobile EDS. So in general, for the most important strategy for the cardiovascular system is increase our circulating blood volume by making sure you've got plenty of water and plenty of salt on board. And it's important to do both of those things because the kidneys are going to balance your water and salt. So if you take in too much water that's not balanced by the salt, the kidneys are going to say, uh-oh, our ratio of salt to water isn't right here, so we have to get rid of the water. So you're going to put it in and pee it out. That's why we really need those electrolyte supplements. In general, we say the amount of water that you're going to try to consume is about half your body weight in pounds. So if your body weight is 140, half of that is 70. That's the number of ounces of water that you're going to shoot for every day. And then the electrolyte supplementation, salt stick capsules, liquid IV, the new one, tablets, any of those are going to give you more sodium and potassium. And I generally recommend to start around 2 salt stick capsules twice a day, something like that. Tube of the liquid IV or 1 new one. The new ones are they're like little fizzies that you put in a bottle of water, and they make an electrolyte drink out of your water bottle. And if you're getting enough water and still having that woozy, dizzy, pre-syncope kind of thing, increasing the electrolytes is a good idea, but obviously you don't want to do too much. So the maximum for the salt sticks is 8 salt sticks a day, the salt stick capsules. Compression garments are another good idea. They help ameliorate the pooling of the blood in the legs. So because the people with EDS have the connective tissue is more expandable and looser, the veins can dilate more. And the veins in the legs, the valves are necessary to push the blood back up from the feet up to the rest of the body. Those valves are made of connective tissue. So it's kind of a double whammy. The veins are not functioning optimally, and the compression garments can help get the blood back up to the rest of the body, the central part of the body, to the heart, the lungs, and the head.
I think the problem with that, though, is that I'm sensitive.
It's one of those things where it's a compounding problem. And the other thing with the compression garments is they can be really hard to put on if your fingers are very hypermobile, right, or unstable. The brand I've been recommending it's a company called Bauerfeind, Bauerfeind, And Bauerfeind was a textile company before they started making medical devices. They mostly make braces. So their fabrics are really nice. They're easier on the skin than a lot of other ones. And they also make a thing called a donner, D-O-N-N-E-R, which, to don your clothing is to put it on. So this is a donner for these compression socks. And I've seen videos showing how it works, but I still can't really wrap my mind around exactly how it works. But it's a piece of kind of slippery plastic that goes in between your skin and the sock, and it makes it easier for you to pull it up, and then you can get it down. Oh, can you explain it to me?
Yeah. I mean, OTs use it a lot for like hip. Yeah. As long as you don't scrunch it all up into one area and kind of like let it be about this large and put the sock on, it usually has a rope too that you can where it's tricky for you. You just kind of go fishing for your foot and then you slide it on and gravity pulls it right up. So sometimes people have difficulty loading it onto the donner, but I feel like it was overall a lot.
The popular nurse.
Yeah, I think I got one after Zippy.
So what you were saying about the vein dilation, is that reversible? Like if your vein, like is that something it's not like they dilate and stay dilated? Is it that it's like a flare up, and I take it that the valves don't dilate to fully close with, like, does the valve stay the same size and that's what
Yeah. So I think it's a dynamic thing. It's not something that happens all the time, but like when you're upright, just gravity is going to keep the blood down in your feet and legs. And when you put your legs up, like if you lie down and you put your feet up on a pillow or something, then the blood will come back down and the veins will go back down to their normal size. It's an elastic situation.
Another added benefit of exercise and general strengthening to improve tone, because think about your muscles also as pistons. If you know, like power mechanics, right, a piston will also pump fluid around. So as your muscles activate, contract, and relax, it acts as a pump to help increase blood flow back up to your heart as well. And if you have better resting tone, you're going to have improved pump back up to your heart.
So I guess one more thing about compression garments, which is that the people who take care of patients with EDS in France use compression garments a lot. I had the opportunity to visit a clinic there a couple of months ago, and they have this woman who's like a tailor. She comes in and she does about 60 different measurements, to make these custom compression garments, and they use them to help people with proprioception. So for a lot of people with EDS have difficulty, they sort of don't know where their body is in space. And part of the problem is that the sense for proprioception is in our joints, and we rely on the position of the joints to sort of tell us where things are. And if the joints aren't in the proper alignment, then we don't know where. We tend to walk into walls or have difficulty knowing where to put our feet when we're walking on uneven terrain. But these compression garments keep the joints in better alignment, and they also give input from the skin about where your body is. And so people find that it's really much easier to function in many ways when they're using these compression garments. It can still be a problem with the mast cells, however, so we got to get those mast cells under control. Yeah.
So Mike recommended a brand, it's CWF, and it is a compression garment, and it also acts kind of like KT tape, where it wraps around, and I have very unstable hips, and it holds it in place and helps it from subluxing. They're like 115, 120 on Amazon, but before my feeding tube, I lived in them because they were just so comfortable, but they hit the wrong spot. But
yeah, I mean, I think it's really difficult to get the custom ones covered in the U.S., but there are a number of brands that are available just over the counter, so that CWX is one. You can find compression leggings, compression vests, and compression upper garments, tops, online. So that's another thing to think about. And the compression undergarments, like the Spanx undergarments, they can do the same kind of thing that you're talking about, like to help kind of hold things in place. You just need a little bit of assistance with that. I think everybody who has a diagnosis of hypermobile EDS, we should have an echocardiogram to look at the valve functions, not only the mitral valve, but also the tricuspid valve. And we want to look at that aortic root. And then sometimes the hydration and the salt just isn't sufficient, and we need other medications to help. So Florinef is one, and Midodrine is another that sometimes will be prescribed to help with the improve the POTS symptoms. There's another class of medications called the beta blockers that slow down the heart rate. And so if your resting heart rate is just really high, then sometimes the beta blocker will be prescribed. The earliest beta blockers were, propranolol was the very first one. And the thing about propranolol is that it does cross the blood-brain barrier, and so it exerts its beta blockade effect in the brain, and that can make people tired. So the next generation of beta blockers were things like atenolol and metoprolol. They do not cross the blood-brain barrier, so they're better for use during the day. But if people are having a lot of trouble sleeping at night, and it's that high sympathetic tone, that fight or flight mechanism that's keeping people up, then sometimes propranolol at night will cross the blood-brain barrier and will help calm the brain down and help with sleep. And then the last drug that's being increasingly used for POTS is something called ivabradine. That is it's a specialized kind of a beta blocker that does not drop the blood pressure as well as slow the heart rate down. So it slows the heart rate down but doesn't drop the blood pressure. And that has been really, really useful for a lot of people with POTS. However, it's not FDA approved for POTS, and so we're in a situation where a lot of insurance companies won't cover it. The drug was FDA approved for congestive heart failure, and I believe it's now been approved for sinus tachycardia, so we can possibly get around the problem with not being approved for POTS if we can document sinus tachycardia on an EKG, then the sinus tachycardia can be the diagnosis that's used to justify the ivabradine prescription. Okay, in the nervous system, many issues, as you all know. So I've heard Fraser Henderson give a lecture talking about headaches and EDS, and I think he listed like 14 or 15 different kinds of headaches. So that's a lecture in and of itself. And I know that many of you have different kinds of headaches from different sources, from the occipital region back here all the way to temporomandibular joint issues and muscle tightening all around the scalp and so on. So different strategies for dealing with those headaches depending on what is the cause. I'll talk a little bit about the cervical medullary syndrome in a minute, but those are the symptoms of the cervical medullary syndrome, are the things that we see when we have instability at the craniocervical junction or a Chiari malformation. We may have neuropathic pain that's caused by compression of nerves at any of a number of places. Anywhere where you have an unstable joint, you run the risk of compressing nerves. There's the syndrome of occult tethered cord in adults. So in children, the tethered cord is often visible on MRI, but we don't see it very well on MRI in adults, because what happens is that the phylum, which is the band of connective tissue that wraps around the cord at the base of the spine, the phylum stretches out as we grow, and therefore the radiographic hallmark of the tethered cord, which is a low placement of the conus being the bottom part of the spine where the the spinal cord comes to a point, and then below that you have the cauda equina. So usually that conus sits at L1, L2, and when there's a tethered cord in a young child, the tether pulls it down, pulls the conus down, and the conus is sitting L3, L4 sometimes. But as the child grows, the phylum stretches out, and the conus kind of goes back to its regular place at L1, L2. So by the time you're an adult and you're worried about tethered cord symptoms, you do an MRI, the conus is L1, L2, but that doesn't mean that it's not tethered. So that's why we call it occult, because it's not obvious on the MRI. And we then depend on various neurologic testing or urologic testing because the nerves that go to the bladder are often pinched off with the tethered cord, and we get urinary urgency, frequency, incontinence, those kinds of things. So looking at a test called urodynamic can tell us if the nerves that are going to the bladder are being pinched, and that's a really good hallmark of tethered cord. Yeah.
Just curious, in urodynamics testing, they said I had neurogenic bladder, and then whenever I had the MRI, they said I didn't have tethered cord.
Right.
Does that mean I could still have?
Yes.
Can we talk about that more?
Yes.
Okay.
Yeah, because it's an occult tethered cord. It can be an occult tethered cord because it looks like it's fine, but it's really not. So yeah, we'll talk about it later.
Great, thank you.
Yes.
Can you also see urine with that? Or
Yes.
Is that just the
Yeah. You can see urinary retention. You can see incomplete emptying of the urinary bladder. And some people with EDS just have a huge capacity of the bladder. You know, they can hold like a liter in the bladder, which is pretty unusual. But with a tethered cord, what you might see is that as the bladder is filling, you don't have a perception of being full until it gets really, really, really full. You know, and then that's why you have that urgency. Yeah.
Is it possible that Interstim, like that they could add a Band-Aid on or cover up of that? Would it be like without the proper treatment?
Yes, because what the Interstim is doing is providing the stimulus to the bladder that is lacking as a result of the tether. So the nerves aren't giving this proper stimulus to the bladder, but the Interstim is helping with it, so it will improve the symptoms.
I think that makes sense. I just know like spinal cord pathology or things like that, will it?
I guess the problem is that if there is a tether, the nerves, it's not just the nerves to the bladder that are being impacted. So you're ameliorating the situation with the bladder, but if there are nerves that are going to the bowel that are being impacted, or the nerves that are going to the legs, then you're not doing anything to help those with the Interstim. So those symptoms will persist and until you alleviate the tethered cord.
Is it something that is aggressive, or is it?
So I haven't seen a really good natural history study of tethered cord in EDS. I've had some patients where it's just remained kind of static and we haven't had to do anything about it, and somewhere it's tended to get worse. There's Dr. Petra Klinga is a neurosurgeon who's done a lot of work with tethered cord. I mean, that's really her specialty. And she's started looking at the phylum as that band of connective tissue that wraps around the cord, and she sees mast cells in there under the microscope. So one of the theories now is that the mast cell activation can be exacerbating the tether and making it worse, and sometimes causing it to recur even after surgery is done. So those mast cells are, they can get into trouble in lots of different places.
Some of the kiddos that I work with that don't have EDS but do have neurological problems and they've had, at least the surgery is fairly not very invasive for people with EDS.
Yeah, no, my impression is that the tethered cord surgery, of all the neurosurgeries that people have to think about with EDS, it's probably the least problematic. It's the quickest recovery. People are usually back up and walking around the next day, and it seems to be pretty straightforward. I would never say any surgery is trivial. it's not. It's a major surgical procedure. But of the neurosurgical procedures in EDS, it seems to be the easiest one to tolerate. All righty. So the venous insufficiency is not only the one that's kind of made worse by gravity in the legs, but sometimes we see venous insufficiency in the brain. So you can have cerebral venous insufficiency, and if the veins aren't working properly from the brain, then you get the backup of blood inside the brain, and that in turn influences the flow of cerebrospinal fluid, and so you can get increased pressure in the brain as a result of that, and that's another cause of headaches. Degenerative disc disease is something we also see really, really commonly. People, even in their teens, sometimes we see degenerative disc disease. People can look like they're having back issues that you wouldn't expect until a much older age. And then the spinal instability has to do with the tendons and ligaments that hold the spine together. And small fiber neuropathy is something else that Dr. Wu mentioned yesterday. No, Dr. Penman mentioned yesterday. I think we don't know the full extent of small fiber neuropathy yet in people with EDS because it does require a skin biopsy to make the diagnosis. But if there's a high suspicion of that, it's worth doing because, as she mentioned, there are some situations, if there's an autoimmune cause, there are things that we can do like with IVIG or the other procedure. And there's another procedure for treatment of autoimmune conditions that can be used for small fiber neuropathy. So just a little bit about this cervical medullary syndrome. This came about, there was a consensus statement that came from the Scientific Advisory Board for the Chiari and Syringomyelia Foundation, which is now called the Bobby Jones Chiari and Syringomyelia Foundation in 2013. And the first things are headache, suboccipital pain, or neck pain. And then there are the symptoms that are related to problems with the cranial nerves. We call these the bulbar symptoms, and those include altered vision, including double vision, or nystagmus, which is where the eyeballs are kind of shaking like this when they looked from side to side, problems with hearing, dizziness or imbalance, the room spinning kind of thing, problems with choking, or difficulty speaking, the dysautonomia and POTS, which include the syncope or pre-syncope, problems with the sleep architecture, and sleep apnea. So these are all problems with the autonomic nervous system, really. And then symptoms of myelopathy, including weakness, clumsiness, spasticity, altered sensation. Paresthesias means feeling of kind of pins and needles or unusual sensation in the skin, changes in gait, and the urinary urgency and frequency. So really a wide gamut of things. But if people have multiple of these symptoms, then we think about cervical medullary syndrome and do the imaging that we use to try to identify that. So the upright MRI helps us to look for instability between the skull and C1, and we do the upright MRI sitting, not a standing machine, but you're sitting and it's an open MRI, and you do it in neutral and then with your neck in flexion and in extension. And we look, there are certain measurements that are taken to assess whether there's instability there. If we have a very high suspicion for cervical medullary syndrome based on our exam and the symptoms that people are reporting, and the upright MRI is normal or does not show instability between the head and the neck, then we look for instability between C1 and C2, because that can also give many of those same symptoms of the cervical medullary syndrome. So in order to do that, we look at the CT scan of C1 and C2 in rotation. So for that one, you're lying down, and then you put your head to the left and to the right. And C1 C2 is a funny vertebrae. It's a really unusual vertebrae. It has this little thing that's called the dens that sticks up like a finger from the vertebral body, and C1 wraps around it like this. And when you turn your head, in general, those two things are going to move together. But if there's instability between C1 and C2, C1 will move off of C2 this way, and that kind of pinches the spinal cord as it travels through that opening coming down from the brain. So the CT scan allows us to look and see, are we unroofing the side of C2? How much of the side of C2 there that we ordinarily wouldn't see is visible because C1 is moving off it? That's what we're looking for. And the radiologist also looks at the angle between C1 and C2. They should be lined up right like this, but if C1 is moving, then there's an angle like this that the radiologist can measure. So in general, if people, yes?
Would that explain why a swallow study neurology for choking?
If this neurologic problem is causing the choking, then the swallow study would usually be abnormal, because it's a consistent thing, but it may be dependent on position. And that's something to think about, like when you're having the trouble swallowing, are you sitting in a certain way, or are you?
I will say, when they had me do the swallow study, they kept telling me, no, sit up straighter, 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 and I only had swallowing issues on like the more dense food items, but I choke a lot. Like my husband can even recognize it now, because I kind of like stopped moving and kind of like, it happens so frequently that the people that I regularly eat with know, and they're like, Heimlich, are you good, kind of thing. So I would love for that to.
If it's related to problems at the craniocervical junction, then it might be.
Is this the same as craniocervical?
Yes.
Oh, okay.
Well, yeah, that's what we're looking for, is the craniocervical instability with that MRI of the cervical spine in flexion and extension. That's it. That's the one.
Meeting ergonomics would be important.
Speech therapy.
You can test speech therapy, and then thinking about what posture you're engaging in. You could even retest small foods. You don't want to choke yourself out to confirm your suspicion. That's something that you can really associate and pull into your life.
And there was an excellent paper that just came out early part of this year from Dr. Leslie Russick, who's a physical therapist up in upstate New York. Ryan's done some work with her, and she had a committee of people that did a very comprehensive look at best practices for optimizing function in people with craniocervical instability before considering surgery. So that's something that I think is really useful. Leslie Russick, R-U-S-S-E-K, is the first author on that. And we can post that paper and make it available to you. All right, now for the GI manifestations, we had Dr. Wu gave us the whole song and dance yesterday about this. So there really isn't a whole lot more for me to say about it, except that it is a source of misery for many, many people with EDS, and just a wide range of GI complaints and issues and concerns, including the irritable bowel syndrome, bloating and abdominal pain, the esophageal reflux, food intolerances, problems with stool, either too much or too little, too fast, too slow, and the hernias and that sphincter of Oddi dysfunction that we mentioned very briefly towards the end. So such a wide differential diagnosis when people come in with abdominal pain and these issues. And you have to think about gastroesophageal dysmotility, just plain old dysautonomia, that vagus nerve not operating properly. The mast cell activation can play a really important role in GI disturbances and small bowel overgrowth. So it's really important to understand exactly what the cause is in order to make sure we get the right treatment.
Anecdotally, like for me, I'm diagnosed with mast cell, but I really don't have a lot of like skin reactions besides adhesives. But I do notice that when I am the most consistent with my diet and like my quercetin and things to control mast cell, my GI tract is so much better. Like that's where I noticed the biggest difference.
Yeah.
And we talked about how mast cell can cause like chronic inflammation and things like that. So that's like over the years, that's where I've noticed the more symptomatic management.
Yeah, it's really interesting because we know the mast cells can play a role in every organ system. We think of the skin as being the most obvious one. That's where people kind of go, and if you don't have rashes, hives, itching, then they tend to discount it. But many people have symptoms in other organ systems without having them in the skin. So it is important to think about that.
Could that be why, if the mast cells are more managed, why I can sometimes eat my triggering foods in small quantities, but then whenever I'm less consistent, it destroys me?
That's exactly right. So the mast cells are putting all these inflammatory molecules out into the tissues, and if they're inflamed, if they're misbehaving, you've got a lot of histamine in the skin, you've got a lot of histamine in the GI tract, and adding the foods that are triggers just kind of puts you over the edge. It's kind of like a bathtub at the brim, and you put more water in and it's going to overflow. But if your mast cells are under control, there's not that much inflammatory molecules out there because the mast cells are holding onto them, they're staying inside the cells, then a little bit in moderation, those foods that do the triggering, you'll be able to tolerate. The bathtub's only half full, no overflow. Yeah, I think that's a good strategy.
If you need it, I have a list of those.
I don't know what I did with.
So I have the website on here where you can go and find it whenever you need it, but it'll come up when we're talking about the mast cells. In general, for the GI symptoms, though, our general strategies there are what we call prokinetic medications, which help improve the motility of the GI tract. A number of those that are available for us now. And then if mast cell is suspected, we want to do that trial of mast cell treatment and look for the food sensitivities and allergies and eliminate the allergens. Laura was telling me this weekend that she had testing. She found she's allergic. It's a true allergy, not a food sensitivity to dairy and what was the other one? Eggs, dairy and eggs, yeah. And so when she eliminates those, she just feels a million times better. So it's important to make sure we eliminate those too. The mast cells play a role in true allergies as well, but what the allergies are IgE mediated. So it's a form of an antibody, the IgE antibodies, and they're the ones, so if you make the IgE to, let's say, egg protein, then when you are exposed to the egg protein, the IgE comes into play, it binds that allergen, and then it hooks onto the mast cells and triggers the mast cells to react. So the mast cells are the end result, but it's IgE mediated. And with the mast cell activation in general, it's not IgE mediated, but the mast cells are just misbehaving on their own. So the mast cells are part of the immune system. And it seems like when people have mast cell, there is a tendency for problems with the immune system, so that you have more of a risk, I think, of autoimmune problems. But the mast cells per se are not an autoimmune phenomenon.
For testing for food allergies, is that something where you can go and just get across the board, or do you, for allergy testing?
Yeah, so the allergies, there are skin testing, and then there's also blood tests. So they look for, I think they look for the IgE in the blood test, and the skin testing they do the pinprick with the allergens and see if you react to it. So I have what I call my mast cell 101 protocol, includes antihistamines, and I have a slide on this. We'll come to it. I'll talk through it in a minute. Now, the urologic features, we were talking about this a little earlier with the tethered cord discussion, the urinary urgency or burning on urination, difficulty starting the urinary stream, difficulty emptying the bladder completely, urinary dribbling or frank loss of control, and then a sensation of frequent urinary tract infections, particularly if you feel like you've got a urinary tract infection, but you go and they look at the culture and it's negative. No bacteria there.
I saw this very small study in the UK about if the urine was cultured longer, that then it would show positive for a bacterial for individuals with EDS.
It is interesting, and I'm not familiar with the study, so I can't comment on it. Sorry.
Feel confident on the study, but
Yeah, I don't know. In general, I kind of think of when you have a culture negative sensation of that inflammation in the bladder, often it leads to a diagnosis of what they call interstitial cystitis, and that just means inflammation in the tissue of the bladder. And that is often a mast cell problem. So frequently the chromalin sodium, which stabilizes the mast cells, will help with that symptom. Again, for the genitourinary symptoms, there's a wide range of things that can cause those things, and we shouldn't go automatically to one thing, assume it's a tethered cord or assume it's the mast cells. We have to do the studies to make an accurate diagnosis, and then the treatment will follow from when we know what's the underlying cause. So in general, a urology consultation is a good idea, and it's really good if you have a urologist who's familiar with these various things that we see in EDS. Yeah.
So is a diagnosis of interstitial cystitis, would that be accurate, or is it really just because when I went to the urologist and they did a cysto, they diagnosed cystitis. So do I not actually have interstitial and I have mast cell? Well, I already know.
No, you have both. So the mast cell is causing the interstitial cystitis.
Okay.
It's inflammation of the bladder. Cystitis just means inflammation of the bladder, and it's because of the inflammatory molecules that the mast cells are putting out.
Because it kind of seems like since the dysautonomia causes us to mimic so many other things that we don't always have positive tests for things that we have symptoms for. So I never know what's an actual interstitial cystitis. I know can happen on its own. So I didn't know if I had two things or if it's have this thing and then it caused. I don't know. That's what's always confusing to me.
So in that case, I feel pretty comfortable saying that it's the mast cells are causing the inflammation, and the presentation in the bladder is the interstitial cystitis. Just like in the skin, the mast cells cause hives. We call it hives, we don't call it a mast cell thing, we call it hives. So it's the end result of the mast cell inflammation.
So the disorder can its own thing and a symptom.
Yeah, and I think of it as a result of the mast cell activation.
With bladder installments, are they targeting mast cells with that, or I don't know what else is that?
The bladder
Installments? I know there's a pelvic center in Evansville, and that's all they call them. I don't know what it is.
Yeah, I don't know either. Sorry. So we'll have to get Dr. Powell to come the next time. But sorry, I don't have an answer to that one. All right, we're running a little bit behind here, but we've talked a lot about the allergies and hematology issues in the mast cells. Many things going on in hematology and allergy. We can have the hives, rashes, flushing, itching. Those are all emblematic of the mast cell activation. Frequent infections. There does seem to be an increased frequency of primary immunodeficiency among people with EDS. So checking for primary immunodeficiency, if people have had a really big history, many more infections than you would expect for a person of their age, it's worth looking at the immune system. And then the autoimmune disorders, this is something that hasn't really been extremely well studied yet, but my impression just from the patients I've seen over the years is that I see more people who have autoimmune conditions than I would expect to by chance, just for the population that I'm seeing. And then there does seem to be also an increased frequency of blood clotting, but also bleeding. It goes both ways. So those things may need a hematologist to evaluate them. Bless you. So in terms of the mast cell activation, the tests for mast cell activation are very specific, but they're not very sensitive, which means that if they're positive, they're very helpful to us in establishing a diagnosis, but if they're negative, it might be a false negative. So if the suspicion is high for mast cell, whether it's skin findings or GI findings or things going on in the lungs or the bladder, I do this, what I call my mast cell 101 protocol, which includes antihistamines, because the histamines are one of the major inflammatory molecules released by the mast cells. So H1 and H2 are the receptors on the cells that the histamine interacts with. And Zyrtec is your H1 blocker in general. Zyrtec, Claritin, Allegra, Benadryl, those are all H1 blockers. And H2 is going to be your Pepcid. Tagamet is another one. And then the mast cell stabilizer is going to be the drug that holds those mast cells together and prevents them from releasing the inflammatory molecules that are inside the cell into the tissue. And so cromolyn sodium is usually the one I start out with. That requires a prescription. If there's a problem getting that because of insurance coverage or for whatever reason, then we go to quercetin, which is a herbal supplement that's available over the counter. And that one also stabilizes the mast cells. And ketotifen is another one that has to be compounded, but that's just a 1 milligram tablet once a day. So sometimes that's easier for people to take. And then the higher histamine foods, that histamine food list is found at this place, that histaminintolerance.ca. And all the foods are ranked, the foods and food additives. It's a very extensive list. And you can take a look at the one that Sarah has with us. But each food or food additive is ranked from 0 to 3. The 0s and 1s have minimal histamine effects, and the 2s and 3s progressively more so. So what I usually recommend is to limit the food intake to foods labeled 0 or 1 for 3 weeks. And then each day after that, you can add in one food that's either a 2 or a 3. And keep track of your symptoms with that. If the food causes pain, causes rash, hives, abdominal pain, bloating, respiratory problems, urinary problems, just keep a little diary, and then you'll know what you're reacting to.
0 to
0s and 1s for 3 weeks.
And then what did you say you could go up to?
Well, the only two things left are 2s and 3s. So the foods are ranked from 0 to 3. So it's either 0, 1, 2, or 3.
But then you could reintroduce. Okay.
Mm-hmm. Yeah, one food at a time each day, one additional food. Sometimes this is enough. Sometimes this makes a huge difference for people. Their GI symptoms get much, much better. Sometimes their pain gets much better. I mean, we've heard really people come in and say it changed my life, just these simple things. But sometimes it's not enough. And so if this is 101, sometimes we need a graduate course. And then we need Dr. Jin, who's our allergy immunologist, and he can help with the next levels. Yes, I usually do recommend both an H1 and an H2 together. So, and usually what it is I usually recommend Zyrtec, which is over the counter, 10 milligrams once a day, and then Pepcid, 20 milligrams twice a day.
H1 and H2 or a stabilizer?
Both. All three things at once.
Okay.
Yeah, we do all three of these things simultaneously.
That's what I
Yeah.
was I wasn't overdosing.
No. Yeah. Pepcid AC is fine. Yeah. Mm-hmm. And you heard yesterday about these coping strategies, and I think we're going to hear a little bit more from Alicia about these things today. Chronic disease is hard. It's hard living with all these symptoms. Having a toolkit of coping strategies is really, really important. And I realize I have exercise on the bottom of this, and it is very helpful for coping, but it's also so important for so many of the other things that we were talking about, that it belongs here, but it also belongs in just sort of your general well-being. But I will leave the rest of this to Alicia for later. So thanks for your attention.